Just a few minutes on the adult guidelines, although they really won't be on the guidelines, because the guidelines are available to you. There are copies right here, and I do not plan to go through level 1, 2, 3, 4, 5 for each one of the diagnostic classifications for adults, most of which are, I assume, or all of which you're probably pretty darn familiar. However, I would suggest that you do look at some. What I would like to do is spend just a few minutes talking about some stuff that has struck me during the course of my clinical work in reviewing cases for a couple of years now under Medicaid, and what I see and hear when cases are brought up for discussion at rounds. Just some points that I think are clinically important for me, and I hope for you too. And then we'll spend just a minute. We'll go over the audits, but that'll really be just for a moment. Okay. Look, the guidelines now with FMHI are really no different from the guidelines that were originally, in terms of concept and approach, that were drawn up back in the late 70s, starting in New York State. As a matter of fact, for those of you who are interested in Dead Sea Scrolls, I actually have one of those manuals with me. And I think you would be shocked to see how little difference there is between the guidelines that we put together then, including what was called then the exception system. Exception equals edits. In other words, when certain combinations of drugs were prescribed or certain doses. But in those days, it was a little different. Might as well have some anecdotes here, because we had a computer system for all of the hospitals, some 36. And when a doctor wrote a prescription, if any of those exceptions were important, the prescription would not be filled for that patient, because these were all inpatients. At the state hospitals, we had 60-odd thousand patients. And the doctor would have to justify why he or she was writing something that was essentially beyond the guidelines. In which case, unless it was some weird thing, it would be filled, but he'd have to justify it. The only thing different when I look back at these guidelines in New York State and now, essentially, are doses. Still had the stuff about more than 2 antipsychotics, still had concerns about more than 2 antidepressants, still had concerns about duration of drugs without any kind of evidence of efficacy, all that stuff. All good, simple, common sense stuff. But the doses were different then. You know, up to 100 milligrams of Haldol was considered okay. And 2,000 of Thorazine. Remember those days? Well, so, you know, if there's a lesson to be learned from this, I think, is that increasingly in the face of these uncertainties, and especially with the kid stuff that you're facing now, especially now, but even with the old-time adult stuff, really we come back again and again to the primum non socera thing. Our first obligation is not to hurt anybody. And I think if there is something we can do to reduce hurting in terms of side effects that are debilitating or outright dangerous, I think that's our first responsibility. Having to do with combinations, having to do with side effects, having to do with duration. I don't know of any better way to watch over this than using schedules, than using something that we can rate. And I never see this in adults. Almost never. For example, schizophrenia, fine. Psychotic, has delusions, has hallucinations. Don't know how much, what kind, what intensity, how often. Is it getting better or not getting better? It's usually yes or no. And you all know that's not the case. It doesn't work that way. So you really, at least I don't, in looking at these records, and believe me, I see a lot of them, I have no way of knowing what's going on with these patients. And, you know, without wanting to sound terribly cynical about it, you know, there's often a rather dramatic change when benefits have run out in terms of what is described as the clinical picture. But won't get into that now. So, you know, let's not hurt these people. And I think another way of not hurting is to have some sense of the diagnosis. For example, we're very often given diagnoses of schizoaffective disorder. I think in 2 years with the Medicaid program, I have never seen any specific criteria for that diagnosis listed in the record. And it requires, folks, specific criteria. Remember? Uninterrupted for a couple of weeks and at least 2 weeks of psychotic symptoms without an affective syndrome. So, is schizophrenia being treated, or is it an affective disorder? And you really don't know. You really don't know. And if I were to say one thing clinically that concerns me the most, in the patients, at least the records that I see, it's the lack of the definition of bipolarity in a patient who comes in with severe depression. That is, there's no thorough investigation of the history to find out whether or not there was some mania in the background or hypomania. Terribly important because these people are put on antidepressives. And the switching rate into mania goes up like this when you do that. And it's really a bipolar illness rather than a major depression per se. I think anybody in the business would say, look, you've got to have a history, and probably equally as important, you've got to talk to the family. Ask some questions about mania or anything like mania. Never see it done. And of course, what happens with these patients in particular, the Medicaid patients, they're put on these medications and no one ever changes it. It's like forever, like being put on Dilantin in the old days because someone said you had a seizure, and someone had a seizure. No one ever takes them off. Okay. 2 other quick things. All of this may pale next to the necessity of follow-up with these patients with psychosis after they're discharged. If I were to pick one thing, the lack of follow-up in this population is probably the most devastating. And by that, of course, because the lack of follow-up is correlated so closely with lack of adherence to medication, which also, as subset A, brings up the other consideration, which is, in my opinion, the need to put these people on depot until proved otherwise. And I mean from day one, including first episode schizophrenia. And those of you who haven't followed the literature lately may not know that there's a 60% non-adherence rate within 1 year after the first episode. Play with it. 60% of people after their first episode stop taking it within a few months. And of course, you know what happens to relapse rates. So they're starting now to put first episode kids, you know, teenagers, young adults, on depot as the drug. You know, they've been doing this in Europe for years and years and years, and we haven't caught up. I'm not sure why, you know. But I would say those 2 things, follow-up and depot. The other thing that isn't being used that should be used, in my opinion, this is not FMHI, clozapine. It's the best antipsychotic on the market. Every person will tell you this. Nothing even approaches it in terms of efficacy. But everyone is scared to death to use it. And you really don't need to be if you set up some system. Really don't need to be. Not only that, but the aplastic stuff can be handled now, you know, with medication. If somebody is around who recognizes it and knows how to do it. So it's really kind of a shame, I think. And it's true not just here in Florida. It's true throughout the entire country, of course. I'm just speaking now, you know, in kind of wish fulfillment stuff as a clinician. Clozapine's a fantastic drug. Okay. In reviewing this stuff, I couldn't help but be reminded